sharing our videos, but if they can sort it out before then, that's great. Yeah, it's still not working. The host has to allow it. I'll text them so they can arrange. But in the meantime, we can make a start. So hi, everybody, and welcome back to this healthcare section of Dimensions XR. Thanks for joining us. We've had some great talks in the morning, setting out the, I guess, the vision around where XR has come from over the last few years and where it's heading towards. This is going to be a really exciting talk from Dominik Fischer, who works for Brainlab. Brainlab is an amazing company doing some incredible things around navigation tools and neurosurgery and others. And they've been heavily involved now in the whole AR robotics world. So this will be really exciting. This will be cutting edge. And I'm so excited that they can join us to share their experiences and what they feel can be their vision for the future of XR. So Dominik, sorry we can't see you on video. Hopefully we get it sorted out. But the floor is yours, as they say.
Thanks a lot. So thanks a lot for these nice words of introduction. Also, I'm happy and it's a pleasure for me to be here to tell you a bit about what Brainlab is doing in the field of XR. It has become a pretty important topic for Brainlab over the last 2, 3, 4 years, I would say. I personally was involved in this topic all the time. So I'm leading the product management activities for Ministrality and surgical robotics. Wonderful topics in these days. So it's a lot of momentum, lots of things happening. And I think one of the main stories I want you to take home is that it already exists in hospitals today. So it's not about a vision and some things for the future, but it already is used in hospitals really to prepare surgical procedures already today. And now I will jump into the teaser video in the next slide. It shows the vision of where we want to go. We are not there at the moment, but I think it pretty nicely tells the story. So this is now the scenario where you would use the Ministrality headsets in the OR. And this is actually something many surgeons dream of. So you would have the overlay onto the patient using the images that were taken before surgery. So this 3D model based on MRI images or CT images that would just be overlaid onto the patient, accurately displayed. And this would be an incredible benefit for the surgeon to have that. And we are not there yet, but we are on the way. And right, this is something else that is really interesting for the future. So you would have virtual screens instead of physical screens. Then you can arrange the content you need to have as a surgeon. You can arrange within the room, just make sure that you get all information at the right moment, at the right place in the operating theater. This is also something which is not rather the perspective of the nurse and not of the surgeon. Nurses have the challenges that a lot of instruments are involved in the procedure, and it's not so easy to always pick the right one when the surgeon is asking for it. Imagine having the nurse a headset and injecting the information about the instruments, about the name and what it's supposed to do, and other information. That would make the life of the nurse a lot easier, like you see here. And of course, you can think about really nice interactions to work with the content, with the virtual content. I think this kicks off the story very nicely, where we want to go, or where a lot of people want to go. And that's the status where we are today. So that's a pretty high-end operating theater, actually. You see tons of displays. And this is now one of the most important ways to transport information to the team, to the surgeon, to the nurses. It's via normal standard displays. And this is, again, a look into the future. Here, it looks very different. So you don't have any physical displays anymore. What you have is a series of virtual displays, which of course can be customized in the size and the dimension, because you're not limited to any physical dimensions anymore, like today. Well, the display can only have the dimension of 28 inch because there's only so much space for it. In this virtual environment, you can just arrange all your displays the way you want to have it. And as I said, the holy grail for me for this topic is this overlay of the preoperative information onto the patient, like you see here for this brain tumor case. And this would be very, very helpful for the surgeons. But I want to, before I dive a bit deeper into the topic, I want to spend a minute on telling a bit more about Brainlab. So we are our headquarters in Munich. You see this picture below is actually where I go to work usually. At the moment, I'm in home office. It's the old tower of the old Munich airport, which was now converted into, yeah, we have some operating rooms in there for demonstration purposes. And that's part of the new Brainlab building, which is at the border of Munich. So we have about 800 people there, and all the R&D activities of Brainlab are in Munich done. In total, we have something like 1,500 employees worldwide. We have many offices, 19 offices. The second biggest one is in Chicago, which is a really big market for us, the US market, obviously. And a bit different from other medical companies, we are very much software driven. So a lot of the things we do are based on software. You will see this in a minute. And that's also one of the reasons why we really, I think, pretty far advanced in the fields of XR technology, because it's kind of our DNA to look into these software applications. And we have a really big footprint that helps us to roll out our Ministrality application. So more than 5,000 hospitals are already using Brainlab software. So now it's not easy. So we have our target customers already defined, and I'm sure many of those will use Ministrality applications very, very soon. So in total, we have more than 10,000 systems installed worldwide. So that's a really good starting point to introduce XR technology into hospitals. This picture shows what Brainlab is doing actually. So maybe you're familiar with the navigation system. So that's the thing here on the left. It's in the first place used by neurosurgeons, but more and more by spinal surgeons, but also by ENT surgeons. And it's kind of mapping the MRI images and CT images you were taking before the procedure. It's mapping onto the patient, which is lying on the table in the OR. So you can compare it somewhat to Google Maps you're using. Instead of the maps in Google Maps, you would use CT and MRI images. And it doesn't show you the way to the next supermarket, but it shows you the way to the tumor, for example. So once you move in your instruments in the navigation system, it tells you precisely in which position you are at the moment based on the CT images and MRI images. That's a common technique nowadays for neurosurgery, for spinal procedure, for these kind of procedures. It's not used for abdominal surgery. That's the problem of the soft tissue, which is much harder to navigate. But for these kind of procedures like brain tumors, it's almost standard of care, or it's standard of care. So that's a big thing we are doing. And we are also doing radiotherapy, so treating patients by radiation. So that's the other big division we have. And so it's all around treating tumors. But what I will now focus on a lot is on surgical planning. So really being prepared as good as possible from the surgeon point of view on the procedure. So you can do some planning upfront that allows you to be very well prepared for the procedure and for what's coming there. And the other thing is anatomical mapping. That's the task to really understand the information of the preoperative images. So it's not about only gray values and white values. It's really understanding the different structures within the CT scan, like understanding where in the CT scan is a brain or the ventricle. I come to that in a minute. In the meantime, I can switch on my video if it works. Now I can't stop my video. Can you hear me?
Yes, we can hear you.
Okay. So we do it sound only, and we skip the video. So that's the starting point of many things we're doing. So many things that are done in hospital. You got the images of the patients on the right-hand side, MRI scan, on the left-hand side, MRI scan, right-hand side, CT scan. So that's the baseline. And now we're start to create a 3D model based on this information. And looking into the past, we came here. So 2009, I think there were the first attempts to create a 3D model based on these 2D slices. So if you get a brain scan, typically you get a scan with 200 slices, 2D slices, like the one here right next to the hand. with a difference, with a distance of 1 millimeter to the next slice. And this is the base for all the surgeons to define their surgical strategy, which works very well because surgeons are, they're very much used to think in these 2D slices. But of course, it's much easier if you can convert these 2D slices into a 3D model, what we did here. So this model here you see on the big screen, this is based on the MRI data set you see on the left-hand side of the screen. And of course, this is much easier to understand for the user than only the 2D slices. So that was about in 2009 when we stepped into visualization of 3D models. A few years later, you probably can remember Avatar in the cinemas, and everybody was crazy about 3D films in the cinemas. And the TV vendors, they started to sell 3D televisions. That was the point where we looked into improving the 3D perception for the users, for the surgeons. And what we did is we had the 3D model normal display, and then we injected the 3D model in the 3D display. And but you had to wear the glasses. So you had to wear these special glasses, polarized glasses. And in this way, you could feel the 3D model much more like a real object compared to the display where it's just something plain. That brought us a lot of interest by the surgeons. So it obviously improved the 3D perception, but in the end it was a bit too clumsy. So we had additional display in the OR. The clinical benefit was there, but it was not huge from the feedback. So it was good. It was really a start to improve 3D visualization, but we saw it's not what the people want to have in the long run. And then another 3 years later, we were looking into these devices you see on the head of these people. So these are the Magic 1 devices. And now the 3D model jumped from the normal display into a 3D stereoscopic display. And now the 3D model jumped into the Ministrality devices. And that's a huge step. So 3D perception on a 3D display, if you have tried it, it's good. It feels quite like a 3D thing. But this was a huge step to have the 3D injected into Ministrality. And actually, this is the point where surgeons understood the value of a better 3D visualization of preoperative MRI and CT images. And this was really astonishing to see. They were initially a bit reluctant because they didn't believe in the benefit. But even the very experienced surgeons admit after a while wearing the headsets that they now know more about pathology of the patient than before. It's really amazing how much you can get out of this kind of 3D visualization. Yeah, we have the product now out. It's CE cleared, it's FDA cleared. It's used in hospitals, and its feedback is just very, very great. So it's fantastic to be responsible for a product like this. All right, so how does it work in real life? So let's go through the different steps one by one. When you start with step number 1, so the image acquisition. So you got the CT images, MRI images. They're done by radiology. In the end, they're on the PACS system. And that's the place where the images are stored in the hospital. And in the end, you want to be at step number 4. You want to have these 3D models right in front of you, wearing a HoloLens or a Magic Leap 1. And step number 2 is you need to take care about the creation of the 3D model. So now you need to decide what kind of information I really want to see for treating this patient. And when you define the structures, you can then create a 3D model. And the last step is then injected into the Ministrality devices. So, okay, step number 1 is without Brainlab. That's just taking images at the radiology department. And number 2, Brainlab comes in place. And this is now the first step. So we are looking now into a liver case with a liver tumor. I'm not an expert, but you see here, you see the lesion. And we have a very nice way, a very nice tool to define 3D structures in MRI and CT images. We call this Smart Brush, and I showed the principle. I think the video shows the principle very nicely. So now I want to outline the tumor. I click on this brush, and then I roughly go to the borders of the tumor. And you see it grows automatically to the borders of the tumor. So it's what we call semi-automatic. And then you do it in the different orientation. So it's growing to the borders. Here we go. And based on these two definitions of the sizes in axial and sagittal orientation, it creates a 3D model. Here we go. So now it created a 3D model. You see it on the top left, you see the red thing. This is now the tumor defined based on this outlining process. And getting the 3D content right, that's very important if you want to help the surgeons to provide them a strategy for treating the patient. It's not only about technology, it's a lot about the content and the creation of the 3D content that helps the surgeon. And in the past, this procedure of outlining a tumor, you had to do it slice by slice. And you could spend easily half an hour to define a tumor like this. And now it's so much easier. Now it's a matter of a few seconds. And then you have a very good representation of the 3D model of the tumor. And this is critical just to have the 3D model that is as good as possible, just to find your surgical strategy. So now, using this software, we have now solved the problem of outlining the tumor. But for this case, what we have here, this liver tumor case, you want to see more structures. So the tumor is not enough. And what we did at Brainlab is we created an avatar. You see it on the left-hand side. So it's a completely labeled artificial patient. And so all the structures, anatomical structures, organs are defined within this synthetic patient. And that information is then merged onto the real patient data set. So it's kind of a elastic image fusion merging process. And once that process is done, you can go back to the software. You see here this pull down list, and then you can pick the anatomical structures you are interested in for this specific case. And of course, in this case, I picked liver. So the software created a 3D model, a 3D object for liver. You see it's pretty accurate here with the borders of the bluish thing here, with the borders of the object with respect to the real anatomy. But for another case, you could choose to extract the lungs or the heart or the gallbladder, whatsoever. So it's like a library of anatomical structures. You can just take things out just to define the 3D model that helps you for preparing the case. And this is what we have achieved so far. So on the left-hand side, we did the automatic segmentation of the liver. It's done. And on the right-hand side, we did this semi-automatic segmentation of the tumor. The two very important structures in the 3D model have been now defined. And as I said, this is a matter of minutes, I would say, so it doesn't take a long time. And based on this information, we can now start to have a look at the 3D model on a desktop display. That's the first step. So what did we do? We outlined the liver, and then we take only the liver volume out of the CT scan, so we can forget about the rest. So we cut the liver out of the data set. You see it on the right-hand side. So it's a transparent liver object. But now you want to have more information about the inside of the liver. One thing is obviously the tumor. You see it in brown. But for Mr. Surgeon, the relationship between vessels, veins, and arteries and the tumor is very important. So therefore, we also extract the vessels out of the CT data set. You see it here on the left-hand side, these white spots here. These are the vessels going around within the liver. And these are then also visualized in our 3D liver model. This is now giving a pretty complete picture for the surgeon to understand the anatomy and the pathology of the patient. So we create patient-specific 3D models based on the raw 3D data sets. And this is what we did for a while. This is the 3D data set still on a normal display. So we have not talked about Ministrality headsets yet. But just to give an idea about what we can do nowadays is in terms of 3D modeling, these nice pictures. Left-hand side is a pretty complex, advanced model of the brain. So you also see the very realistic textures we put onto the structures. You may know that Brainlab has acquired a company called Level X. They're very big in games for surgeons, but serious games for surgeons. And they're also very good in in modeling of anatomical structures. So now they are level X is defining the structures you see here. So for example, the ventricle looks like it's really very much like water filled. So it's kind of bridging the gap between a textbook where you have these beautiful images of the patients, but the models are not patient specific. And we are taking the real data of the patient. So it's a patient specific 3D model, but at the same time, we managed to have the models as realistic as possible by using these textures. And further down, you see the optic nerve, the brainstem down here, and the cerebellum down there. So that's a new surgery model. On the right-hand side, that's a pretty simple model. So what I did here with the different planning steps, that's only needed for more advanced models. If you want to have just like this pelvic trauma fracture, you just take a CT scan, click on one button, and then you get a 3D model of the patient. So that's a very easy way to create a 3D model. So that's done maybe in a second and not a minute cycling the other one. So this is also possible. And other examples like top left, you see an implant for a patient, for craniomaxillofacial patient from the CMF department. You can also visualize the implants. Bottom right, that's a spine patient. You see the screws that are about to be placed in the back of the patient. This is also done using the Brainlab planning software. You can automatically place the screws and then later use it for your procedure. In the middle, you see here the new textures we have for lung and for liver and all that. So we have now found a way to create these realistic 3D patient-specific models. And now we need to bring them into the goggles, into Ministrality. So far, everything we did was on the display. So you do it as you always do it. And then you click one button and then you get a QR code on the screen. And then you put on the Magic One, you start the application on the headset. And the first thing after starting the application is it tells you to look at the QR code. And then you look to the QR code with the headset, and then the data is transferred from the PC, from the desktop machine into Ministrality. So, and again, this is just a matter of seconds. And after that step, everything you saw here on the display, these 3D models, they are injected into the headsets. So these four guys here, they're all seeing this 3D model floating in the middle of the room. And to make sure that everybody sees the model at the same position in the room, we need to define a common 0 point of the coordinate system. And this is what you see down here in the bottom right corner. So we have a small piece of paper with that texture on that. Then you look with the device, you look on there. Everybody is doing that. So this arrow is identified by the goggles, and this is then defining the common 0 point. And if every participant in the session is doing that, everybody can see the 3D model at the same position in the room, which is very important for the interactions with the 3D model. So everybody can look into the same direction. And you see it already here. It's obviously it behaves like a 3D model. So it's very much different from a display, which is just flat. So all these guys here are seeing the 3D model from different perspectives. And we see that this helps a lot in any kind of communication between surgeons. So this immersive appearance of the 3D model in the middle of the room. And we support multiple users in one session. We say we go up to 4, we can do a bit more. It's rather limited by Wi-Fi than by technology, but that's a very important feature that several people can join that session and study a 3D model simultaneously. Speaking about the hardware, that's the hardware we are using. That's probably you may even know it. It's the Magic One. It's a pretty lightweight headset, which is cool because the thing in the middle, that's called the light pack. So it's detached from the headset itself. So this is just in your pocket. So there's a small PC in there, and our Brainlab planning station PC is communicating with that device here, and then information is injected into the goggles. So you see tons of sensors and cameras. And on the right-hand side, I think this is very important, a very nice piece. That's the Magic controller. You see several buttons. So there's a touchpad here, there's a home button here, there's a treater and a bumper. And this is a very, very nice tool to interact with the 3D models. So you can do rotation, you can point at structures. It's a very intuitive way to control the 3D model. So I would say this is much better than any kind of interaction using hands for this specific use case, because it's very, very precise. And yes, again, this is what I was just explaining. So you drop the different buttons in there. So the touchpad is really nice. You can really slide with the thumb, and then you can have different layers on the 3D model. And another comment for the implementation we did this year, you see here this small help menu. That's also one of the big advantages of this technology, that help menus on a desktop PC are always kind of disturbing. But here you can have them very easily placed right next to the 3D model. And that's a very nice way just to let the user know how to interact with the system. So we see very steep learning curves. It depends a bit on the age, to be honest. The younger guys are usually pretty fast because they're used to this technology. But overall, everybody in 3, 4, 5 minutes is able to interact smoothly with a 3D model. And now I have another video for you. So that shows the interaction. So that would be the step, let's say the old-fashioned way to review the images. You have the display, and it's a touch display, and then you see the CT scan, MRI scan, and you already see these additional structures on top of the raw data, which were defined by you in the Brainlab software. And now you can rotate the model. And this is kind of a 3D thing, but it's, go back. So this one here, this was done for years to have a look at 3D models in this fashion. So you can rotate the model, you can look at every angle to that 3D model. But it's very much different to have that as a 3D hologram in the headset. So this is something Surgeons appreciated, but it was not very, very common to look at 3D models, to be honest. But now I think it's really changing, because now everybody's understanding the benefit of the 3D models, because they are just so immersive, what you can see in the headset. And now that, oh, sorry for that. So this is now the click on the Magic Leap button in the user interface. You click on it. Once again, sorry for that. And then the data is injected into the headsets. This is really annoying here, transport the video properly. Now the model is injected into the headset. You can have the model right in front of you. So that's a laser pointer that helps you you can really move the object. Using the touchpad, you can make the model bigger and smaller like that. You can make it a meter diameter. You can rotate objects using the controller, like that you see it here. But you can also add the 2D slices, like you see here. Now you can peel the different layers. And here you can add the 2D information right on top of the 3D model, which is very much appreciated by the surgeon, and then scroll through the different sizes. So I think it doesn't replace a real demonstrations, because you can only really see the benefit if you have seen it in a real hologram using the devices. But I think this tells how it's used with the different kinds of interactions. And these are now 2 examples of surgeons using our implementation in real life. There's on the left-hand side, you see 3 neurosurgeons from Oulu University in Finland. They use it now as a part of their daily routine for complex cases. They use the Magic Leap devices, our software. On the right-hand side, that's a different discipline. So you have the CMF surgeons at the University of Heidelberg. And here you see the segmentation of the different components of the skull, which helps them to decide about how to treat that special patient. So they like it very much. You see, they often do it in teams. I think that's very interesting to see that a lot of benefit comes from the team sessions. So not only one surgeon looking at the images in this 3D fashion, but it's teams. And it's a lot about interdisciplinary teams. So often neurosurgeons, they invite the ENT surgeons or the CMF surgeons to be in one session. And then you have these joint sessions between different disciplines. And this is very, very helpful because these 3D models are a very good platform to discuss the strategy. So if you compare it, having members of different teams looking at the 2D display, it's by far not the same interaction as you see here, having members of different surgical teams in one room looking at the same 3D model. So that's one of the biggest surprises to us, that the collaboration is so important for this review of these models. And that's some feedback we got from the surgeons, just some clinical insights. For the neurosurgeons, aneurysms are very interesting use case, like on the left-hand side. So you have cranial aneurysm, because 3D understanding is very crucial if you operate somebody on the aneurysm. And the other thing is skull-based tumors, very complex tumors close to the skull base. Also there, you need to have a really good strategy to operate on the patient and how to resect the tumors. And as I said, collaboration is very important, and also these interdisciplinary meetings. And we see so far 3 use cases for Ministrality. And so far, I've only talked about the preparation of surgery, just to inform the surgeon as good as possible before he or she enters the operation room. But there are also 2 other really important use cases. The one is patient education. You see that something's wrong in this picture that was coming from the old days where we were using the 3D display. But this is now changing. So people now get the Ministrality device as a baseline for the discussion between the physician or the surgeon and the patient. It's probably not something for everybody, but we get the feedback that many patients, they feel much better after discussing the case by using this technology. On the one hand side, they understand obviously much better the pathology, because MRI sizes, CT sizes, they are not understandable for a normal patient. So they just do not understand what the surgeon is talking about. So then they get a 3D picture, which is obviously much easier to understand for a patient. And the other thing is it gives the feeling of being at the right place for the surgery to the patient. So they see at this hospital, they're using the latest technology. And that increases the confidence of the patients into the hospital and into the technology. And I think this is also really important. And in the US, we see it's also used as a marketing tool. There's much more competition between the hospitals, and if you can offer to the patients that they can view their cases in using Ministrality technology, it's a reason to go to this hospital. This trend is not that strong in Europe, but I think it's will grow in the future. And number 3 is teaching, education to students, to younger surgeons. We got a lot of feedback that from the experienced surgeons that it's almost unfair that the younger surgeons do now get this technology to learn how to operate on the brain, because it takes years, 5 years, 10 years to become a really good neurosurgeon. But they all say the younger generation, if they can use these technologies, they will have a much steeper learning curve, because the understanding of what to do of the 3D relationship between the structures, which is really relevant to be a good surgeon, this will happen now much faster than using a conventional textbook with the pictures inside. So this is something that comes in almost every session. So they think about the preparation for the procedure, but they also think about the younger surgeons and the way to become a good surgeon. And at the last part of this presentation, I want to dive a bit deeper onto a publication that has just been published. It's a group of surgeons in University of Munich in Rechtse Isar. It was published in the Neurochirurgica these days. And it's about teaching and training of neurosurgeons and neuroscientists. So we had a session of the European network of the low-grade glioma network. And we have 15 scientists and surgeons with at ISA. And some tumor cases were then discussed by using Ministrality. And it's about the dissection of the white matter. Well, the title of the of publication is Augmented Reality for the Virtual Dissection of White Matter Pathways. And the white matter, so I took it from Wikipedia, so that's the white part of the brain. That's kind of the highway in the brain where information is transferred. So I'm not a neurosurgeon, but that's a very easy picture, and you see it in the bottom right. You see this very colorful picture. These are kind of the highways you see in the brain. So you need to have special MRI scans, TTI for the experts. And based on that, diffusion tensor imaging, based on that, you can extract these 3D models by using the software. And then you get the 3D information of the tumor, but also on these white matter tracts, which are very important to plan the procedure because these structures are very relevant. Many of them are referring to your ability to speak and to move, so for motion and for language. And if these structures are damaged during the tumor resection, it can have quite some negative impact onto the patient. So it's really important to preserve these structures during tumor resection. And so far, I mean, this knowledge about these structures, it's mainly based on cadaver dissections. And yeah, cadaver crosses are losing popularity more and more because they're expensive, you got limited availability. Probably for some things, there will still be need to have cadaver crosses, but many things you used to learn in cadaver crosses then can now be done by using extended reality technology. And the goal was really here in this course, to understand the benefit of mixed reality for this kind of training. And what we did is we took 5 patient data sets. They had left-sided gliomas. So you see here the 5 patients, and you see here that's the outline, the skin model, and so you see the tumor here. And in some pictures you have additional information like the ventricles in blue, and the tumor in brown, but also these fiber tracts. And this is a focus on one I picked because very nice you see here. So in blue you see the ventricle, in brown you see the tumor, and the red tracts are for language. So these are the language-related fiber tracts, and the orange one are the motor-related fiber tracts. So this is information that can really be extracted from MRI images, which is already quite amazing. But you see that the 3D structure of these fiber tracts are very complex. And of course, mixed reality is a perfect tool to better understand the 3D positioning of these fiber tracts and then plan your surgical procedure accordingly. And this was actually mirrored by the feedback of participants. So we had 15 experts there from neurosurgery, neuroscience, neurolinguists were also present in that session. And then they rated their experience. It was a scale from 1 to 10. 1 is not so great, 10 is fantastic. And you see it's something like 8 point something. So 8.5 in mean for the overall experience. Say that, yes, this is a very nice way for fiber dissection courses. The benefit was seen a bit higher for students than for the surgeons, which is quite obvious because students they can benefit even more from these technologies than the experienced surgeons. But overall, I think this is a really nice result to have a result of 8.5 out of 10 points to use mixed reality technologies for these kind of training sessions. On the bottom right, there's a picture from the session. So you see the participants, and they have all these laser pointers. So this is very interactive. You can point at structures, and then the expert can explain a bit more what they're seeing. All right, and so this is what we have today. So that's, as I said, it's market released, it's used in hospitals, and of course we're working on new things to come, and of course this will be in the next steps. So far, most of things we're doing is in the office, which is very important, as you've seen. But if you talk to surgeons, they all want to use the headsets into the operating theater, of course. And that's now the big challenge to manage that. It's about overlaying the structures at the right position onto the patient, like you see here. So you see the information from the final procedure. But the other challenge is actually on the side of the vendors. So far, none of these headsets are really major devices. So neither HoloLens nor Magic Leap, they are medical devices that can be used during the treatment of the patients. So we need to have a new generation of these devices, what will come. But that's another talking point at the moment, to have these kind of technology used in the operating room routinely. Actually, that's it what I want to tell you. I hope you enjoyed what I was telling you, and now I'm happy to listen to your questions if there are any.
Dominik, thank you so much for that. You can share your video, by the way. I think it's been enabled if you need to, see if it works.
Yes,
so,
I will try. Let's see.
Let's hope it works.
No, cannot. The host has stopped it.
The host has stopped it. Let me see if I can let you share. Let me. Okay, I'm going to make you.
You disabled us, Shafi.
Now try it now. See if that works for you.
Okay, I'll try again. Yes.
Oh, we can see you.
There I am.
You do exist not in the virtual world, of course, but in the real world. So I'm glad.
Yes, I do.
Great. One thing I like about Brainlab presentations, they were so beautiful, right? The pictures, the quality, it's amazing. So it's always nice to see the level of quality that you provide. So a few questions from me, I guess, at the beginning. And then if anyone has a question from the attendees, please feel free to either use the chat or indeed you can actually just unmute yourself and speak directly to our speaker. So question from me. We talk about hardware and we keep updating hardware from Microsoft HoloLens 1 to 2 to Magic Leap. We're not sure what's in the future. The problem a lot of people have with developing these ideas is that the goalposts change constantly. Yeah, the new handsets, new hardware coming out. How do you keep on top of that as a company regarding constantly evolving your platforms?
I mean, that's obviously a challenge. I mean, if your technology is young, like this technology, you kind of need to expect that there are changes pretty often. And I think, I don't know what the official life cycle is of these devices. I think it's maybe 2 or 3 years between 2 generations of these devices, so that's very rapid. When our first customers, they are very happy to have the Magic Leap 1 in their hands, but at some point in time, they will need to have the new technology.
Yeah.
I think what we will need to do is to give them an easy upgrade path from the old to the new technology, because I'm sure they all want to have the new technology in their hands once it's out. But at the same time, I think if it's not the office of the head of the department, if you talk about students and you want to have 20 headsets in one session for teaching, I think you can live for a long time using the not the latest version of the technology, because also with that version number 1.0, what you see here, you can do fabulous things. So I can imagine that they can live for 5 years or longer in these kind of contexts. But if you're talking about then use in the O.R and the latest, greatest, then these customers need to switch to the latest technology, latest generation.
Yeah, and that makes sense. Some people are having models where you can actually hire them out, purchase them on a regular basis, and perhaps do hire purchase agreements. As it's updated, you get the new equipment. So people are looking at different models of that kind of acquisition, I guess, from that perspective. Secondly, is just a while ago, about a year ago, I think one of the papers mentioned, there's an article about not being able to operate effectively with a HoloLens or a Magic Leap new device, because you've got slim view and also restricted view. It's sometimes a bit heavy, a bit cumbersome. So a lot of people get confused by actually operating with the headset on, and actually just for pre-planning, right? Just planning, understanding. What are your thoughts around that, Dominik?
So, well, I mean, everything you're seeing in public, in websites or pages where you see somebody using the HoloLens on the head, operating on a patient. That must be a matter of ethics committee, or it's not illegal. It's not legal in the inner sense, because it's not a medical device. So there must be some special regulations to do that. The generation as we have it, they're not made for that use, because you have this special regulatory paths you need to follow. The other thing you were saying was the field of view, what you're seeing. That's a very, very valid comment. I mean, this is one of the most common feedbacks that we get. It's all great, but why can I only see like that? And I think we can be sure that the manufacturers of these devices, one of their main goals is to increase the field of view for the next generation. I think from HoloLens 1 to 2, I think they made quite a big step. And the same will happen with the next generation of the other vendors. That's so far a big limitation of Ministrality devices, that the field of view is limited.
Sure.
Shafi, if I may.
Yeah, so yes, go for it,
Yeah, quick question. Great to see you, Dominik. This is Rafael Grossman. I had a chance to try the mixed viewer last year in Berlin, and it's phenomenal. My question is, do you think that we will ever bypass the computer? You know, the reading the QR code with the Magic Leap. It's a good way to do it, but I kind of being a trauma surgeon, I kind of dream of the time when I am in the trauma bay and I have a Magic Leap on, and the images are being gathered on the patient from the CAT scan, and they are being beamed to my device directly, like a PACS device on my Magic Leap or HoloLens or whatever the device might be.
I think that will come. I mean, there are good reasons why to do it like we did it.
Yeah.
First of all, it's very close to the workflow they are doing anyway. So you see, it's like for a Brainlab customer, it's the same work as they do every day. But now, if they want, they can add Ministrality. But all the rest is the same. So you don't need to get used to a completely new workflow. And the other thing is, some tasks you need to get the model onto the patient overlaid. There are some tasks to do. For example, you need to choose the patient somewhere. Somewhere you need to type in the name of the patient. And that's still quite a cumbersome procedure in the headsets. So if I need to type in the password of the Wi-Fi, it takes me a while using the Ministrality device. So,
yeah, no, I'm always thinking voice, you know.
Well, yes, I think that will come. I mean, let's say I would call this an intermediate phase. Obviously, from a user point of view, you don't want to have two different systems to interact with. You just want to have one. You want to switch on the device, you want to select the application, and then you want to go probably to choose the patients from the PACS system.
Yeah.
And I think that will come, because this hybrid approach, what we're doing today, I think it works very well, but it's not the end of the story.
Absolutely. No, that's great. Thank you very much. It was a great presentation. Thank you.
Thanks.
Good to see you again.
Okay, so last question for me is around, you just mentioned about your future story. Are there any thoughts about connecting your devices to the electronic health record or the EMR in the future to make seamless transition? You mentioned PACS already. I'm thinking more about the data acquisition and I guess the EHR as a tool.
Absolutely. I mean, you can imagine any kind of content. I mean, the big thing about these glasses is that content is always at the right place. So it's always in front of you if you want, and it's not on the table somewhere or in another room. It's always with you. And then in the end, it's just a matter of injection the right content at the right moment. I mean, we think about looking then to the operating room. So you can think about the content changing depending on the phase of the procedure. So you would see other content appearing right in front of you at the start of the procedure, and then it changes from step to step of the procedure. And I think this is something one can do, so that you can really intelligently adapt to the situation you are in. And the same, if you have the drawers on, you walk through the hospital. If you probably could identify the room in which you are. So which patient am I going to see next? Yeah. And this could be already put automatically from the EHR. So showing, and these are text files, so this is super simple to display. So there's no reason why not to do that. It's not the closest for us because we are more located in the O.R, but this is something that will come.
Sure, it kind of makes sense. And any thoughts about general surgery? You've obviously done neurosurgery very well for a long time. I'm a general surgeon. I'd love to see you doing things with us. What's your plans for general surgery, if you have any?
I mean, I talked a lot about creating 3D models.
Yeah.
And we have these super fancy models of the brain because that's where we come from. The models, what we can do for liver surgery or for lung surgery, they are not yet that advanced, but we look into that so we can structure these anatomical regions. That's part of the strategy of Brainlab too. Not only do the brain of the Brainlab, but to do other parts of the body. So that's not far away to do that. I mean, we have already applications for liver surgeons and We will add some for all the lunch surgeons. You may refer to navigation. One of the big things we're doing is navigation. And all the navigation we're doing is pretty close to bone.
Yeah.
Because that's a nice reference. So it's the spine, it's the face. Mm-hmm. That's the easy way of navigation. And I talked to many visitor surgeons that asked us, when are you doing the navigation for me, for my procedure in the OR? And that's a tough one. And it's soft tissue. It's moving all the time. Yeah. I think that will also come, but that's way harder than having a bone reference.
Yeah, it makes sense. So
it's probably about,
as a current I'll be looking forward to seeing one day using your devices and your technology. Yeah.
It's going to be about video processing. You need to understand the video information from the endoscope and mesh that somewhat to the perioperative images. I think that's theoretically doable. It's just very hard job.
Of course, been an amazing job so far, incredible. So look, I want to really thank you, Dominik, for a really amazing talk. Showcasing what's possible today in the future, sharing all your thoughts of your company, and we can't thank you enough. It gives a lot of people a roadmap about how to do it properly, the validation, the training, the attention to detail, etc. So thank you so much, and we look forward to hearing it more over the next few years. Thanks so much.
Thanks a lot.
Okay, everybody, so that's, I think we've got a few minutes before our next talk at 1 o'clock. So please join us in a few minutes.